and get some red cells, then you may want to let it dwell a little bit longer. Your instruction says let it dwell 30 minutes. If your catheter is non-functional, let it dwell another 90 minutes. Well, we are late on our vancomycin. We don't want to change. And so if I go after 30 minutes and I got not a great blood return, but I got a blood return, I may let it dwell only another half an hour, just so I can, but I will let it dwell until I can get 3 mLs in less than 3 seconds. You need to get a good blood flow before you call it all open.
And if you pull back and all of a sudden you got like 2 and then it stops, so you know that it hasn't called dwell enough, you can take that and put it back in?
Yes. Because what you just pulled is your cat flow mixed with the debris.
Okay.
If I pull 2 ml, I don't like to return debris. I usually will take another dose.
Okay.
But if I get just a tiny little bit, then I put it back in the catheter. But 2
A lot.
ml, that's longer than the catheter. That would be giving the cat flow and the debris to the patient, and I don't like to do that.
Is there a cutoff then? Is it like less than 1 ml?
Well, an ml is probably, this catheter would probably take 0.9 ml, so. Now cat flow doesn't have much, I mean, it's only 2 milligrams. Systemic wise, it's not, even if you give 1 ml systemic, because you've gone through the whole catheter, within 20 minutes it's all disposed of. They're not going to bleed. Or the only patients that cannot get cat flow is the one that's sensitive to, has an allergy to cat flow, or somebody that has active bleeding. So if you had somebody with an active ulcer, and patient that have a possibility of bleeding. If you had somebody that had a visceral biopsy, they went to radiology and had a liver biopsy, you can't put pressure where they had their biopsy, so you wouldn't want to give them cat flow within 48 hours of that. Or somebody that had a delivery, had just had a baby, or somebody that is going to have surgery within 48 hours. Those are the patients that don't get cat flow, but everybody else can get cat flow. If they had surgery 4 days ago, that's okay. They don't get enough systemic. But the best, excuse me, best advice I can give you is when it gets sluggish, work on it then and there. It's easy.
So when you're doing the negative pressure, you have a complete occlusion, how many times do you keep, or how often do you keep going back to apply that negative pressure?
Well, if it doesn't go in, it's not going to work.
Right.
So personally, I mean, you have other patients in between, so I will go in and try, quite a few times, and then I will give it the 10 minute, and then I will go and try again.
Okay.
So let's say it doesn't work at all, you try it 5 times.
It works about 91% of the time. In all the occlusion, the company found that, not knowing how long the catheter had been clotted, they had an 88% declotting rate. So that's quite that's quite. Now I have work on a lady that came from here. It was her port, because you can use it on any central vascular access device. She came in because her port was clotted. I let it dwell 2 hours, and it didn't work. I gave her a second dose because you may repeat cat flow one more time, so they can get up to 4 milligrams. So that makes a dwell time of 4 hours. And in the 4 hours, you have a pretty good declotting rate. But I did the lady, I did 2 hour, I repeated the cat flow, did 2 hour. I even called Dr. Ikosi to give her an appointment to exchange her port. The lady came here to spend the night, but she fell. I don't know if you guys recall her. She went to the emergency room, and her sister met her in the emergency room, and she said to the emergency room nurse, "Oh, we spent 4 hours in the outpatient department today. They tried to declot her port, and they couldn't, so you'll have to put an IV." The emergency room nurse said, "Why don't I try to aspirate? If I aspirate blood, we have a patent port, I'll use it. If not, I'll start an IV." She had absolutely no problem. She aspirated 10 mLs of blood and the port. So sometime, but that's not what the company advertised. The company says 4 hour dwell time, 130 minutes, 90 minutes. You can give a second dose, 30 minutes, 90 minutes. So that's 4 hours. But as also happens on PIC, where we had a gentleman who would not let us change his PIC because he had to go home to get his son. And the next morning his PIC was, we aspirated blood and PIC was functional.
Louise, wouldn't you suggest, because I'm just coming back to me on all the ports I did when I was doing the oncology, that before you go to the cath flow, route,
Do you want to just
to try repositioning the patient. I mean, I've seen ports that if you bring the shoulders down, you try to get the blood and it
And
comes.
what is that called? That's called pinch-off syndrome. That happens with mostly those soft 9.6 French port. Between the clavicle and the first rib, the catheter goes through. And with motion of the arm, they constantly pinch that catheter. Sometimes they pinch it so much that it stays pinched, it sticks together. And also, not just having the problem of fracturing the catheter, you have the problem of what you are describing, pinch-off syndrome. So this patient comes in and says, "You can use my port, but I need to bring my arm up, I need to bring my shoulder back, if the patient needs a special position, he has a port, think of pinch-off syndrome. And you should probably have a chest x-ray to see how serious your pinch-off syndrome is. Because this is the picture of a port with pinch-off syndrome. You see the fracture? So when you aspirate, we were able to aspirate a little bit of blood, but we could flush this catheter beautifully. And when we did the chest x-ray for pinch-off syndrome, because when we put the patient in a certain position, we could always draw good blood. We realized that we had a fracture. So if you're giving Vanco, this is going in somebody's chest. If you're giving chemo, that's going in somebody's chest. So if you don't have a good blood return on a port, do you use it? It could be disconnected here. Have you ever seen how the port is attached to its catheter? It's just a little collar that goes on top. I have seen physician putting the cap on, that little collar, but you see how easy it is for me to get it off? So the catheter came off. If you don't have a good blood return, even in a port, do not use it. Before giving cat flow, is it necessary to do a chest x-ray? No.
I said,
If
probably
you
ideal,
think-
but you're not gonna be able to do it.
If you think you are, the tip of the catheter is still in the right position, there is no need. If your cat flow does not work, you may want to do a chest x-ray and see if we have one of those events where the catheter has now gone to the jugular or is pinched upward. But coming back to our cat flow, we now have instilled it. And we have waited 30 minutes. We have left it in because we did not get a good blood flow. We waited another another 90 minutes. So now we have had a dwell time of 2 hours. Never flush your catheter after you've put cat flow. Aspirate. You should aspirate at least 4 to 6 mLs of blood. That will give you all the debris and the cat flow that is in the catheter. And you throw that out. That's a waste. Then flush it with 20 mLs. And you should be able to flush it gently. That's how you know that, oh wow, that catheter works now.
I do 10 because I'm paranoid. What if? So I'm like, woohoo, if it's coming, I'm letting it come all the way.
Just remember if they have a...
I know their H&H is low the next day, well, Kathy must have given them Kathy.
You're already pulling 6 ml. And this is the time when you just pull 6 ml. Does this patient needs the lab? I've already pulled the waste. Might as well pull my labs. If you can put as much together as you can.
So,
Never put excessive pressure. First of all, you could rupture your catheter, or you could dislodge the clot. Now the clot is going to be in free circulation. Your question, I'm sorry.
so we spoke those 4 things about not flashing occlusions. And we spoke to the jugular vein one, how you know if that's the cause. So what about the other ones, like if it's on the other side, how do you know those
When-
specimens?
Because the catheter tip in the cuboatrial junction or in the distal SVC has so much blood flow. You have 2 liters per minute. It's sitting in a pool of blood. So when you aspirate, it comes easy and it comes fast. It's brisk. Remember, if you have a size 4 versus a size 6, the flow is a little different. When you pull blood from a port, it's a 9.6 French catheter. It comes a little faster than it would with a 4 French. But you pull 3 mLs very quickly. When you are in the jugular, or in the subclavian, or you are in the bronchocephalic, those veins will collapse. They will constrict, so you get blood immediately, but then you don't get blood. And that's why it's so important to know that you can get a good amount of blood in a quick timing. You understand what I'm trying to say? Because you can flush that catheter that is going to the other subclavian, can flush it really well. But as soon as you start, you draw blood a little bit. And when we put them in, that's how I know that I've gone into the azygous vein, for example, because that's in the back of the SVC, is because I can flush and then I aspirate, I can't get the blood. But I pull the catheter out just a few millimeters and I can aspirate. So now I'm gone back into the SVC. And then when I push it back into that small vein.
So in that case, if you have partial or if you have those misplacements, you both get, you can draw some blood, so you don't know which one it is, right? You don't know if it's just partial occlusion or.
I will bet, unless you have, see, you have to look at the whole patient. So if you have somebody that is, has COPD, and now has a pneumonia on top, and he coughed all night long, his intrathoracic pressure was so much that the catheter may have taken a different route because of that. And if somebody said that he coughed all night, he coughed and he coughed and he coughed, and I cannot draw blood, I draw a little bit of blood, I would think, and the catheter was functional up to that time, I could think, maybe we should do a chest x-ray and see if the catheter has migrated. But if it's somebody that nothing has happened to them, I have no suspicion that it has migrated, I would think of a partial occlusion more of a clot. But I just saw one of your patients this past week with blood all the way to the hub that you send for cat flow. So why am I seeing blood? So if there's blood in this part, there must be blood in the rest of the catheter.
Not being flushed.
Yeah, right.
Yeah, that's
Yeah.
the conclusion you,
Did a blood draw or something,
Yeah.
and flush it after.
Right.
exactly. So, or if you see that it looks like there's salt in there, so that's precipitate. Cat flow is not gonna help you there.
So if we suspect that it's misplacement, we send you out right away for chest x-ray or what do we do?
If you think it's malposition, the best thing to do is a chest x-ray. And like I said, if you have somebody that says, oh, every time I turn my head it hurts. Oh, is the catheter in their neck? They tell you every time you flush it, I can hear water running. That's a good hint that it has migrated into the jugular.
And we can just do a portable x-ray, they don't have to go over next door.
It is preferable to have patient having a chest x-ray in radiology. But if you are thinking it's a malposition and you have somebody that is reasonable size, a portable is sufficient. Most of these are from ICU patients, they are portable. The only one is the one from the CAT scan. The others are mostly portable.
So I
But
guess
if you
ovens-
have somebody that is, very big, you may not see the tip of the catheter.
You guys open Saturday and Sunday?
No.
So what do you do Saturday and Sunday if you
I have come here on a Saturday. I came to the clock one on last Saturday.
I mean, it's okay
I
to do
think
peripheral for a couple of days, right, Louise? I mean,
And I
Yes.
think
you know,
we
I think
sent them
we
to
lose,
the, we
we
sent them
lose
to
the
the
con-
ER.
The problem with sending them to the ER is you have nobody that can do anything about it.
Even in the ER, they.
no.
In the ER, and
It's
that's,
Louise or the,
I get that call all the time.
Okay, I see, we thought if we sent them to the ER, then the ER would be able to do it.
No, see, the emergency room has no PIC nurse. No,
So if we send them, they're gonna call you in?
they have, depending on how important it is.
I didn't know that. We haven't, I haven't sent somebody for a while, but I think I sent one.
But
Diane
she's
is
got-
absolutely right. The standard of care is vancomycin, should be given through a central line. But when a patient comes into the acute side of the hospital and they don't have all the cultures back, what they do is they will give them Vanco because it's a broad spectrum and they give them the Vanco. And it is okay to give Vanco through a peripheral vein for up to 4 doses. So if it happens on a Saturday, start a peripheral IV, and you can give them their next dose until Monday morning when you can send them for another pick. The problem arises is when you have somebody with venous insufficiency, you cannot start a peripheral IV. Putting in a midline will not help you. Midline are peripheral IV, and you can give Vanco in a peripheral IV, but you should not give Vanco into a midline. Because if Vanco infiltrates, you can see it right away in a peripheral vein. But if you give it through a midline and the tip is in the axilla, you cannot. That's why I keep saying how important it is to know, do you have a PIC or do you have a midline? So if you are the one admitting a patient with something sticking out of their arm that you think is a PIC, make sure it is a PIC.
What's the midline also, right? That's not big.
That is not a PIC. This is a midline.
Is that for all hospitals? Because I'm wondering, we have seen some that are midlines. I don't know if they were getting say Banco, but is that like a statewide, whether we get a main med patient, CMMC patient, or a St. Mary's patient?
That it will look like a PIC.
If they're on Banco, they won't have a midline, they'll have a.
Well, what happens is that, remember that example I told you? The patient comes in on a Friday afternoon. We try to put a PIC. They have absolutely no vascular access, and the physician says, I'll be okay with a midline. I'm giving a terpenem, Zosyn, I'm okay, just put a midline. On Monday, the patient should be going to radiology to have a PIC line put in. Because now they have to start a peripheral vein just for the Vanco, because it got changed to Vanco on Sunday. But they kept the midline because they can give all the other medication through the midline. But now the patient, he's going to the home. If the Vanco works, it's fine. If it doesn't, it's okay. So they want him here. Don't give the Vanco through a midline. that patient should be referred to radiology for a PIC. As you know, sometimes things fall through the crack. But if I was working here, and they tell me, well, he has a PIC, make sure you get that intervention where it's the nurse that put the PIC or the radiologist that put the PIC has written down where is that PIC. Because if it looks like a PIC, but it has this little peripheral IV, the problem is that, you know, some of the patient, you know, wonders, you know, it's a paper, it's sticky, but they pull it. So be careful. Make sure you know it's a midline versus, it's a PIC versus a midline.
So if you go to Meditech and go for outpatient, you can check it out.
Somebody here showed me how they got into Meditech and they got what I had written for the PIC.
And I can chew it anytime, it's,
But then
So I know you can, because,
yeah.
This is from CMC,
It'll
but
say-
everyone see that.
So CMMC, you might have to call you might have to call the medical records and just say, I need the X-ray results from the PIC line placed
at
at any date.
CMMC, they are placed in radiology, that it be by a nurse or by a physician, they are put in the radiology department. So they would have the record. If it's at main med, they are placed by a nurse, it would be in their record. Just like at St. Mary's, it's part of Meditech.
And I've called before, because we'll have to pull them and we won't have that record. And you should not pull a PIC line or any line without having that record, so you know the length of the PIC and all of that. So you really do need that paper.
And also when they come in first, and you need to know
Right,
measurement.
cause you wanna know what you're given and how long, right, if it's been pulled and.
Here's a question for you, Louise. Is there any, recommended, positioning when you're pulling a PIC?
Patient should be laying down.
Laying down?
It would be good to have the patient with their arm at a 90-degree angle. I do understand that some patients cannot hold their arm in that position. So 45 to 90 degrees is okay. What the intent is that the straighter you take it out, the better. What you need to pull a PIC is what she mentioned. You need to know how long was the PIC. So if it was a PIC in you, probably it would be around 40 cm. So I look before I go, I know I need a PIC that is going to be 40 cm because that's what it says they put in. The other reason, if I may backtrack a little bit, that you want to have that insertion sheet is because it will tell you how much is outside, how much is external, and how much is internal. Because it will say the PIC is 40 cm, but it will say how much is showing. So if it says 40 cm and showing 3 cm, that means that the internal length is 37. Now when you pull it out, you want to have 40 cm. But when you change your dressing, you always want to see 3 cm out. So that's why it's important that you get that information sheet. It tells you a lot. It tells you, I put one in Friday, and it was late, and I knew I could not get radiology to help me out. And I thought, it is better to have longer than shorter. So if I have to pull it 1 cm, it's okay. That was my intention. I wanted it at the cavoatrial junction because I knew somebody was going to get Vanco. And I did not want it in the proximal portion of the SVC, and I didn't want it in the mid SVC. I wanted it deep. I miscalculated. I put 6 cm in the right atrium. Not a big deal. I pulled 6 cm out. The tip is exactly at the cavo-atrial junction, but that means that there is 6 cm that is out. So if you didn't pay attention to that information sheet and you get this patient, you're going to say, oh my God, they pulled it out. And if you notice, sometime I had a lady that, and I'm pretty sure you will get her here, I had to leave some out because her arm was 56 cm. And I could not put the pick as high as I wanted because my needle was not long enough. So I had to put it lower than usual so I could have a needle that was deep enough to go into the basilic vein. Which meant that if I put the stat lock where I would normally put it, every time she bent, she would say, ouch. So the only thing I could think of to make her comfortable and for her to still have a pick was to leave some out so the stat lock, instead of being in this direction, would be in this direction. So she could bend and be happy. You guys would not have the obstruction every time she bent. And so I left some out. So look on that information sheet. It will give you how much. Because I got a call on D3 the other day that the patient had pulled his pick out, and they wanted to know if they should do a chest x-ray, and the name sounded familiar, and I looked at it and I says, how much is out? And they said, oh, 5 cm, and I said, well, that patient had 5 cm out. So if they had looked at that sheet, they would not even call me. That's okay, you can call me anytime, but I'm just saying, if it comes from CMMC or if it comes from another hospital, you may not be able to just call somebody.
Do you have a trick with the static lock too? We find when we change them that the PICC line is so shaky, even though you're trying to keep it as steady as possible, that the PICC line does move. Do you have any tricks to, when you change the stat lock, to keep that catheter from moving?
If you, oh, this is not the,
Because that's supposed to be changed when you change the dressing, am I correct? It's trying to pull it,
something happened this week. Somebody changed the stat lock, correct? It is changed every time you change the dressing. If we just put it in, you may have a gauze dressing. A gauze dressing is changed within 48 hours. All other dressings are changed every 7 days, or if it's soiled, wet, or it's coming apart. When it's coming apart, putting tape around it is not what we suggest. We suggest that you change the dressing. Somebody took off all of it, not just the paper that holds the sticky part, but all of this, and they left just the 2 wings, and then they put the tegaderm on top. So there was absolutely nothing holding the pick. So when you change your stat lock, this is the only thing you take off. Obviously, the best way to do this is after you have you have taken off your dressing, if you put your finger, your sterile glove finger, and you hold it, and you can open your door, this is being left
But that's what happens though, you're trying to do that and you're shaking because you're like, you can't get it off and you're gowned up.
Right?
But I'm left-handed, so I should have done this. So when you open, you have your finger on the pick so it does not come out or anything. Open the door of your stat lock. This is difficult to pull off. If you take your alcohol swab, you can get a little bit under. It will, and you keep pushing it under, it comes right off. But you are always holding your pick. Take off your whole, because if you are holding the pick, even if you move the tail, and you can't move this part of the tails because that's not sterile.
Right.
But if you move, and I won't be able to because now it's stuck forever. But you remove it, and then when you put your next one in, remember one of the tails, those two little pins,
Right.
they move.
Yeah.
So if you put the one in the bottom first, and then the other one, you notice I have another type of stat lock. And some of you have seen the orange needle type of. So we haven't found anything that works
Easier.
easier.
We used to not even have stat ones, we used to suture them in, right, Louise?
We used to suture them in.
Yeah.
Now, when you look, we're going back on pulling our pick. Before you start pulling your pick, you have the number of cm, the length of the pick. You need to get some supplies. What are you going to get?
A mask for the patient.
Dressing.
Gauze, take it in.
Sterile 4x4.
Yeah.
You need some 4x4s,
Yeah.
2x2s. I
Yeah.
always use 2x2s because I put pressure.
Yeah.
But one thing you need to get is an antibiotic ointment. You're getting the antibiotic ointment to close the channel. If I know Diane here will know what I'm talking about. When we used to pull chest tube, there is a track that is left. When you pull a central line that has been in for a long time, I'm not talking about a few days or even a week, but if some of the picks have been in for 6 weeks, 3 months, that track from the skin to the blood vessel is still patent. So when you are going to take out your pick, that track is going to be open. In theory, if the patient takes a nice deep breath just at the moment that you pull it out, they could pull air in their vascular system. And that is why you try to close that track. You don't have sterile Vaseline, so you take any of the antibiotic ointment. At St. Mary's, we have bacitracin. Every time I go to A3, they have Neosporin. I don't know why we have different things. Whatever you have in the Pyxis, that those little one.
We have both, we have triple antibiotic and bacitracin.
Triple antibiotic works as well. It's not for the antibiotic quality. It's just a sterile Vaseline. It will plug the hole. That's all it is for. But you need to get one of those. I usually get a few packages of 2x2s. I always flush my pick before. I want to know if it's patent before. Because remember we have the knot here in this pick? Remember how it goes up and down and up? So when you are pulling this pick, this could knot. And then when you're finding it difficult to pull out, is it because you have vasoconstriction? Because you have a knot? Well, if you try to flush it and it has a knot, you're not going to be able to flush it. If it's vasoconstriction, you may be able to flush it. It's just holding on to the catheter. So also by flushing it, when you flushed it, it moved and the body is really saying, oh, they're at it again. And so when you are pulling it, it doesn't make the vein want to vasoconstrict. So flush it before. If you have somebody that likes to drink something warm before, you have vasodilation, really works easy. Pull out your dressing and pull straight out 4 or 5 cms at a time. You know how long your pick is. In his case, it was 40 cm. So I know I will pull 35 cm slowly, a few cm at a time. When you only have 5 cms left, be ready to put pressure. Ask the patient, would you please take a deep breath and hold it? I don't know about your patients, but not all patients are cooperative. So some are not going to take a deep breath and hold it. That's okay. Just look at their respiratory pattern. If it's somebody that when they breathe out, pull it, put pressure. You need hemostasis. 5 minutes. I always tell the patient, people I train, if they are not on any blood thinners, 5 minutes, check it out. Hemostasis is obtained. Put your, what did you say you had?
Bacitracin and triple antibiotic.
Put your antibiotic in ointment, whatever it is. Fold a 2x2 in 4, so that will put a little more pressure, and put a tegaderm. Keep it for 24, 48 hours. Patient can wash, just pat it dry instead, don't rub it. The tract will close, and then if it looks like it needs a Band-Aid after that, just put a Band-Aid. Make sure you keep an eye on it, that it doesn't bleed. You know how you put pressure for 5 minutes, there's no bleeding, you put a nice dressing and all of a sudden it starts bleeding. So make sure you check on them in 15 minutes, make sure they don't have any bleeding. If they do, well, you change the dressing, put a new little bacitracin and another 2x2 and another dressing after you obtain hemostasis. They're very easy to remove. The vein does not have pain fiber, so they don't even feel it. They've done all their complaining when you took the dressing off.
Give the 2x2 and put top that down, or you take the 2x2
You,
the 5 minutes.
after I put 5 minutes pressure with a 2x2, I put a new one because usually there's some blood on that 2x2. I put a new one and put a tegaderm.
Now, if the person's supposed to have only 3 cm out and they have, let's say 6.
Then that got pulled out.
Alright, so what do you do?
It depends. If the pick was like in that good position, right at the cavoatrial junction, and it had 3 cm out, now you have 6 cm. So that means that it is now 3 cm above the cavoatrial junction. So that means that it's probably now in the mid-SVC. Can you give Vanco in the mid-SVC? Yeah. I would never leave the catheter when I put it in originally, but It's okay, you can give it in the mid SVC. But if this was a very, very difficult insertion, and the best I could do for you was the mid SVC, and we were giving a vein coat. Now you pulled it 3 more cm. Now you are in the proximal SVC. Can you give your vein coat? No. Shouldn't give vein coat in the proximal SVC. So now you have to send them so I can replace the catheter. What is going to happen is, I will tell you, I had such a hard time to even put it in the mid SVC, I will refer that patient to IR. And it's the, we've all done it, we do change the dressing, just a little moment of inattention, we pulled it 1 cm out, never put it back in. No infection, guys, don't push it back in. Okay, you had a bad moment and it's 1 cm out. Where was it when it was put in? If it was at the cable-atrial junction, 1 cm out is no big deal. So don't try to push it back in. But I understand what you're saying about changing
The stat line.
the stat lock.
Yeah,
Yeah.
so that's why I wanted to know if there was any tricks, because,
You hold the catheter with your sterile glove. And if you are one that, we have a nurse, shakes,
yeah,
she'll always say, can you help me out? It's because she
yeah.
The best way would be just to get another person with
If you-
a sterile glove.
Yeah.
That person hold them, you do
Hold it,
everything.
yeah. Yeah, sometimes that's all you have to do is, and when you change your dressing, you obviously have universal precaution, you wash your hands, you have masks, sterile gloves, but you take your dressing off with a non-sterile glove, but.
Right.
And if I have somebody, if I change dressings in the ICU and they are coughing all over the place, I'll give them a mask.
So now, when you're changing the dressing, I noticed the kit we have up here only has one of those Q-tip thing, I think 2 or 3 of them clean.
Just one.
Just one,
Just
yeah.
one.
And I saw online for, they have that bigger clean.
The fluorescent
Yeah.
swabs.
So why don't we have that, is it just,
Cause I think it was shown that you just, with the those chlorohexidine swabs, you only need to go from the center to outside, you don't need to do it 3 times anymore, like we used to have.
Three
you have to do
correct.
three swabs,
betadine
and
and
this
3
one
this.
was, the way this particular disinfectant, you only have to do,
But when you have to use one, just, and I understand what you're
But,
saying, because
yeah.
I do it. I will, because there is only one in the kit, and I do want to wash all around, and it sticks to some patients like glue, and other patients, when you can put glue and it wouldn't stick. But you take a second one and you use the second one just for the, to place it under the stat lock. They come in little swab that are about this big, and then they have the big Chlorasep.
Yep.
You don't need the big one, you need just a little, those are really nice to have when you get in trouble removing the stat lock.
I was just saying, the small Q-tip, I don't know if that was enough to clean,
But you have sterile,
It should be, but,
It should, yeah.
you, do you have the swab, the chloraseptic swab?
The kit doesn't have that, just one small.
we'd have
You
to
just
order
have
them.
it, we have to order them,
Yeah.
but that might be something to look into.
Because you can use that also, you have sterile gloves. The sticks are much better. I agree with you.
But that's enough, right? I mean, studies show that you just need the one swab, that's why
Oh,
we have it.
absolutely,
That's
yeah.
what I was asking,
Yeah,
yeah,
If you
yeah.
just need one
Right.
But,
And you go-
sometimes,
you're going up and down?
yeah. Yeah, you
So
don't have to go
down,
circle.
Out from the
No.
No,
circle.
I thought it was up and down, yeah.
You don't have to go in circle, remember the old fashioned, you have to
Yeah,
go
yeah.
from the, no, this way you just go up and down.
I think I still do it this way, just 'cause that's.
Yeah, I know.
Oh, yeah, that's what's ingrained in us.
I like to
mean,
go,
that's how we
like,
were
I
taught.
go right from the tip,
Yeah,
and
but
then I
then
go
you go
around.
around, yeah, then you go
Yes.
around.
Yes.
Away
You'll
from
be cleaning right there, right?
Right.
I
Cleaning
went to my
right.
capital
Right.
class, I brought my
Under there.
notebook, my pen and my
Yep,
pencil.
and you clean.
And everybody has their notebook.
So when you
out, and
remove
it's not
this-
even an instructor. I'm like, wait a minute, no, I'm from the
Just
90s.
keep on, you clean all this, cause remember you're touching this now.
Yep.
So you're holding it now, I removed this,
Learner.
I removed this, and then I put a new one.
Yep, I'm gonna go
The
around.
most important thing, if I may say, when you change your dressing, make sure your chloroseptic is dry before you put a dressing. If it is wet and you put the Tegaderm, you're going to say the patient is allergic to the Tegaderm. They're really not allergic to the Tegaderm, it's because it was wet under. And then that was what made the rash. Some patients are allergic in our kit. If you remember, the Tegaderm has a white border, and they will have a rash exactly where the white border is. And where just the Tegaderm touches the skin, they don't react. If you see that, instead of using the Tegaderm that is in the